below-knee angioplasty or stenting will actually result in amputation. Just the status of the land, more vascular surgeons and more cardiologists are taking over the endovascular practice in the United States. And I think vascular surgeons are particularly in a unique position to offer both treatments for critical limb ischemia. And I think when you see that everything can be applied to endovascular therapy, you may be biased towards a single treatment. So I think we are, vascular surgeons, in a leading role concerning the treatment of critical limb ischemia, and will be for a long, long time. Having said that, the question is a failed below-knee intervention equivalent to limb loss? And there's failure has many phases. You have technical failures, which are unable to complete the procedure. You may have safety failures associated with that, acute complications, need for acute bypass surgery, need for lost target vessels that may condition bypass surgery later on. You have a clinical failure despite hemodynamic success, with no wound healing, but residual rest pain, limb loss as a huge clinical outcome. And then hemodynamic failures, like Nicholas said before, primary, secondary patencies, and reinterventions. Definitely, there has been a lot of publications about below-knee interventions and a lot of therapeutic approaches, including balloon angioplasty, cryoplasty, stenting, atherectomies, lasers, drug-eluting stents, and drug-eluting balloons. All of them have been studied. All of them have not been randomized control study clearly for the below-knee location. It is interesting because the best guidelines we have out there are really not dedicated to specific endovascular treatment of the below-knee segments. There's limited research, and as you can see, there's different stratifications for the infrapopliteal lesions, and they're all known to us as the task lesions. What I will show to you is that in this particular paper, technical success was conditioned by the type of lesion that you were treating. So if you have a task A lesion to C, the success rate, the technical performance was optimal. When you have a task D lesion, the optimal success rate is not as good. It is interesting that most patients who require below-knee interventions will also require femoral-popliteal segment interventions synchronously. So this is an important point. In this particular paper, there was a 10% complication rates overall. The technical failures were really resulting in 1 immediate amputation and then eventually 8 secondary interventions. Some of them may amputation, may result in amputations in the future. Some of them who are technically unsuccessful, they had residual no procedures. So task D lesions predicted technical failure. And these are the Kaplan-Meier forms that actually, curves that actually shows that. In this particular study, you see that 123 limbs receive also concomitant femoral-popliteal interventions in about 59% of the time. The procedural complications rate were low, with a 2.5% growing hematomas, pseudoaneurysms 0.8%, acute renal failure in 0.8%. The 30-day mortality was actually low in 1.7%. And again, this is a reflection of the below-knee interventions, and you see that primary patencies are about, for 12 months, in the 30%, so a little bit more significantly lower to the previous speaker, and a secondary patency about 50%, and assisted patency of about 50%. The predictors of success or failure in this particular study included renal insufficiency, the need for pedal intervention, and isolated perineal intervention as predictors of failure, and then multi-level interventions or tibial laser atherectomy as predictors of success. Diabetes, smoking, statin therapy, or more than one vessel receiving revascularization in the below-knee bed did not bear any predicting factor. In a great meta-analysis of the literature from the Sao Paulo University, actually, they established about 1,700 crural PTAs with a procedural related complication about 7.8%. And these are kind of the complications that you see there. There is a significant gap between primary, secondary, and limb salvage rates, and I think this is common for every critical limb ischemia modality treatment that you choose. And the primary patency rate at 36% was about 48%. The secondary patency is established in about 62%, and the actual limb preservation rates was about 82%. And there is some, why would you have a higher limb salvage rate when you have a failed intervention? And definitely there may be some persistent critical limb ischemia that hasn't healed, but yet you get to preserve your leg, or there may be proximal PTAs or endovascular interventions that remain patent despite the fact that the below-knee component remains actually thrombosed. The amputation rate actually in the first months, which most of the amputations will be, is about 6.6%, 1.9% in the second month, and then a very small percentage of amputations over time, most likely not due to the actual intervention itself, but mostly due to the progression of critical limb ischemia. Now, the most sophisticated evidence that we have comes from the basal study. And the early data, which was reported 5 years ago now, show very clearly that primary PTA should be the first therapy for critical limb ischemia patients, since the survival and amputation-free survival were the same, and the bypass surgery was more expensive. Now, definitely the outcomes were not stratified by the level of disease, and I can tell you that only 32 patients in this particular study received below-knee interventions alone. Now, the lay data, which was recently updated, show that bypass surgery strategy first gained a significant 7-month history of additional life and non-significant 6 months of amputation-free life over 2 years to 7 years after randomization. Now, this is expected that the patient has to live more than 2 years, which actually was 70% of the cohort of basal. The outcomes of bypass surgery actually were worse when they had to be indicated after a PTA. And again, only 32 patients received isolated crural PTAs. And these are actually the Kaplan-Meier's for amputation-free survival, which is, it's a composite endpoint, and definitely was significantly worse in those patients who had a failed balloon angioplasty than those who have an initially successful angioplasty. So success or failure in the tibial or in the lower extremity interventions definitely actually correlates with amputation-free survival and also affected overall survival. And you see this slide particularly shows the amputation-free survival in patients who receive an initial bypass versus the one who receive a bypass after angioplasty. And you see that both, although it's the same procedure, the bypass who was done after a failed angioplasty actually bear worse over time in amputation-free survival and also overall survival. So in conclusions, I think tibial endovascular approach has a high technical success rate, which is quoted more than 80% of the time. Most of these patients will receive more than just a tibial below-knee intervention. Most of them will actually get femoropopliteal as well, which means that the burden of disease is significant. The acute periprocedural amputation actually is low, so the acute failure may not equal amputation in the short term. The primary and secondary patencies of this particular interventions is actually low. I think we're eagerly awaiting drug-eluting stents and drug-eluting balloons for this bed. Reinterventions are common, and I think it's common for all interventions, including bypass surgery. And on the basal data, a failed PTA does decrease the amputation-free survival. So what is the high-risk cohort in terms of selection, like everything else in vascular surgery, that you wouldn't try to probably do this? Well, TASD lesions in the tibials. When you're not a bypass candidate, I think it's reasonable. When you have renal insufficiency, when you have a need for pedal interventions, when you have poor runoff scores or isolated perineal interventions, these are the patients that are at risk of failure of your below-knee intervention. Therefore, if you fail that, your bypass may actually be compromised. So maybe these are the patients that you should start with a bypass first. Thank you very much for your attention.